Welcome back to the Deep Dive. Today we're doing something a little different. Usually we take a broad look at a topic, but today we are putting on the white coats.
We really are. We're stepping into the shoes of a specialist, specifically an ocular oncologist.
Yeah, and we're digging into global perspectives in ocular oncology, edited by Doctors Bhavna Chawla and Mary Aronow.
It's a fascinating text because it sits right at the intersection of two of humanity's deepest fears. There was a survey mentioned right in the opening.
I saw that, sponsored by Research to Prevent Blindness. They asked people, what's the worst possible medical condition that could happen to you?
Exactly. And the answers were pretty stark.
Let me guess. It wasn't the flu.
Far from it. Blindness was the top fear at 20%.
Okay.
And right behind it, cancer at 18%.
Wow. That is a brutal combination. I mean, usually in medicine, we treat the cancer to save the life, even if it causes damage elsewhere. But here, the collateral damage is the patient's vision.
Exactly. The ocular oncologist deals with both of those realities simultaneously, every single day. That is the high-stakes world we're entering today.
So for everyone listening, whether you're a med student, prepping for boards, a resident, or just, fascinated by this stuff, our mission is a comprehensive review. We're not just listing diseases.
No, we're going deeper, looking at the biology, the global disparities in treatment, the specific genetic markers you need to know, and even the art of diagnosis.
We have a lot of ground to cover. We need to start with the biology of childhood tumors like retinoblastoma, then move into adult malignancies.
Like melanoma, yeah, and the risk factors there, and then get into how big data and AI are sort of reshaping the entire field.
Okay, so if we're looking at the biology of this, we really have to start with the most vulnerable patients.
You have to start with the children.
Yeah, with the genetics of retinoblastoma or ERB.
Retinoblastoma is the most frequent eye cancer in children. Just to give you a sense of the scale, we're looking at an incidence of about 1 in 15,000 to 20,000 live births.
And globally, what does that translate to?
Globally, that's roughly 7,000 to 8,000 new cases every year.
And this is where the global perspectives part of the book's title really hits home. Because depending on where a child is born, the goal of treatment shifts drastically, doesn't it?
It's a heartbreaking divide. It really is. In developed nations, the US, UK, parts of Europe, the conversation has shifted entirely to globe salvage.
Globe salvage. So saving the eye.
Exactly. The survival rates are high enough that doctors are focused on saving the eye itself, preserving vision. They're using these incredibly sophisticated techniques like intra-arterial chemotherapy.
Okay, can we pause on that? Intra-arterial chemotherapy. That sounds incredibly precise.
It is. I mean, it's technically demanding. The interventional radiologist has to thread a catheter up through the femoral artery in the leg.
All the way up.
All the way up to the ophthalmic artery, which is the main blood supply to the eye. Then they deliver chemotherapy, usually melphalan, sometimes others, directly into the eye.
So you're minimizing the systemic side effects because the drug isn't just circulating everywhere.
You got it. It maximizes the dose to the tumor, but it spares the child, the hair loss, the immune suppression, all the things that come with systemic chemo.
But that's the gold standard. What's happening in, say, developing nations?
Well, in developing nations, the primary battle is still just life salvage, keeping the child alive. The source material highlights a study from Brazil that found 70% of diagnostic delays were due to delayed medical referral.
70%.
Yeah. So by the time these kids get to a specialist, the disease is often extraocular. It's spread outside the eye. At that point, saving the eye is impossible. You're just trying to stop the cancer from reaching the brain.
Which brings us to a critical clinical pearl. For our listeners who might be in training, you have to know what to look for early.
Absolutely. The cardinal sign is leukocoria. It's the white pupillary reflex.
Instead of the normal red eye in a photo.
Right. Instead of that red reflection from the retina, the pupil looks white. The book even mentions a study showing significant gaps in knowledge among medical students and residents about this sign.
So if you're a pediatrician or a GP and you see a white reflex in a child's pupil, that is a 5-alarm fire.
It is a red flag for significant disease. Could be RB, could be a cataract, Coates disease. But it needs an immediate ophthalmology referral. No waiting.
Now, one thing that struck me is that because this is a rare disease, an orphan disease, no single hospital has all the data. So how is the medical community solving that problem?
Through aggressive collaboration, there's a wonderful initiative discussed called One Retinoblastoma World, or One RB World.
And it's not just doctors, right?
Oh, that's the key. It unites doctors, parents, and survivors. And the core concept here is crucial for anyone studying rare diseases. The difference between an evidence base and an experience base.
I love that distinction. In cardiology, you have an evidence base, millions of patients on statins. Here, you just don't.
Exactly. So the experience base, the collective anecdotal and retrospective knowledge of doctors all over the world, that becomes your primary tool. One RB World tries to pool that global experience to improve care for everyone.
So with kids, the battle is often about access and early diagnosis. But when we look at the adult population, the biology changes completely. We stop seeing retinoblastoma and start seeing uveal melanoma.
Right. Uveal melanoma, or is the most common primary intraocular malignancy in adults. We see about 5 to 6 cases per million people in the USA.
And the prognosis here is complicated.
It is. We're actually quite good at controlling the local tumor in the eye. We use something called plaque brachytherapy.
Yeah, which is what exactly?
It's basically sewing a tiny radioactive gold or iodine disc onto the sclera, the white of the eye, right over the tumor. It just radiates the cancer from the outside in.
So you save the eye.
Often, yes.
Yeah.
But the real danger with uveal melanoma is its metastatic potential. About 50% of these tumors will eventually spread, and they have a very specific tropism. They almost always go to the liver.
Okay, here's where it gets really interesting for the students listening. You're looking into an eye, you see a spot, a freckle, a choroidal nevus. How do you distinguish a harmless freckle from a deadly melanoma?
This is the aha moment. The book outlines a specific mnemonic called the Molasses system. It was developed to help non-specialists categorize these lesions. If you take nothing else away from this deep dive, memorize this. Moles.
All right, let's break it down. M-O-L-E-S. What are we looking at?
M is for mushroom shape.
Stop there. Why a mushroom? What does that shape actually tell us about the pathology?
Great question. So the tumor starts in the choroid, which is the vascular layer under the retina. Between the choroid and the retina is this tough layer called the Bruch's membrane.
Okay.
As the tumor grows, it pushes against this membrane. Eventually, it ruptures through it. The tumor then balloons out into the subretinal space, creating a neck at the rupture point and a head above it.
Hence the mushroom. It's a sign of a breach.
It's a sign of aggressive, invasive growth.
Yeah.
Exactly. It means Bruch's membrane has been breached.
That makes it so much clearer. It's a mechanical breach. Okay, O is for orange pigment.
Right. And this isn't the brown pigment of the melanoma cells. This is orange pigment on the surface of the tumor. It's actually lipofuscin.
Lipofuscin.
Yeah.
That's a wear and tear pigment, right?
You got it. It accumulates in the retinal pigment epithelium, the RPE, that's overlying the tumor. It signifies that those RPE cells are stressed and metabolically active because the tumor is disturbing them. So orange pigment equals metabolic stress.
Got it. And the rest of the acronym.
L is for large size. Generally, anything with a basal diameter over 10 to 12 millimeters is concerning. E is for enlargement. Is it growing over time? This is why serial photography is vital. And S is for subretinal fluid. Is the tumor leaking fluid?
So mushroom, orange, large, enlargement, subretinal fluid. If you have those, you're in trouble.
Precisely. And the field is also moving beyond just looking at the shape. We're seeing a massive shift toward genetics.
Right. We can biopsy the tumor now and test for specific chromosomal changes. The big one to know is monosomy 3.
And specifically, the BAP1 gene, which is on chromosome 3.
Yes.
BAP1 is a tumor suppressor gene. If a tumor is BAP1 negative, meaning it has lost that protective protein, we know it has a very, very high risk of metastasis. It changes the entire management plan.
So you're screening that patient's liver way more often.
Exactly. Every 3 months with an MRI instead of maybe every 6 or 12. It's moving from, it looks dangerous, to genetically, we know this is dangerous.
That is the future of oncology right there. Let's move to the surface of the eye. We're talking about OSSN, ocular surface squamous neoplasia.
This is a spectrum of disease. It ranges from mild dysplasia, where the abnormal cells are confined to the epithelium, all the way to invasive squamous cell carcinoma.
And there's a geography to this one, isn't there?
Definitely. It is heavily linked to solar ultraviolet light exposure. The risk is highest for populations living within 30 degrees of the equator. In places like sub-Saharan Africa, this is a major public health issue.
How has treatment changed here? Traditionally, I'd assume you just cut it out.
You would. But the conjunctiva, the clear skin over the eye, is precious real estate. You cut too much, you can cause serious problems. So there has been a significant shift toward medical management.
Using topical chemotherapy drops.
Yes, like interferon alpha 2b or 5-FU. It's basically chemo eye drops.
And I imagine that became really important during the pandemic.
Hugely important. The book discusses this in depth. Using drops allowed patients to be treated at home without needing operating room time, which was a scarce resource. And it treats the whole surface, catching microscopic disease you might miss with surgery.
That's a huge advantage. And before we leave the surface, we have to mention the other big one, conjunctival melanoma.
Right, and this is completely different from the uveal melanoma inside the eye.
How so?
Uveal melanoma behaves more like a sarcoma. Conjunctival melanoma behaves like skin melanoma. It's rare, less than 1% of all melanomas, but it has a high local recurrence rate, over 50%.
And because it behaves like skin melanoma, we can use skin cancer drugs.
That's the breakthrough. For advanced cases, ocular oncologists are borrowing from their dermatology colleagues. They're using systemic immunotherapies checkpoint inhibitors like Keytruda and BRAF or MEK inhibitors.
Wow.
Yeah, about half of conjunctival melanomas have a BRAF mutation, just like skin melanoma. It's a great example of cross-pollination in medicine.
I love that. And just for the visual learners, we can't skip the salmon patch.
Ah, yes. Ocular adnexal lymphoma. This is a lymphoma that arises in the tissues around the eye, and it classically presents as a salmon pink patch on the conjunctiva. If you see that fleshy, salmon-colored mass, you have to think lymphoma.
Visuals like that really stick. Okay, let's zoom out. We've looked at the biology. Now let's look at the tools. Big data. You mentioned that rare diseases struggle with data. How is technology fixing that?
Well, in the U.S., ophthalmology has this massive database called the IRIS Registry. But historically, it had a major flaw for oncologists. It tracked things like visual acuity, how well you see.
Because that's what general ophthalmologists care about.
Right. But it didn't track the things that matter for cancer, like metastasis or death.
So you knew if the patient could read the eye chart, but not if the cancer had spread to their liver.
Precisely. It was a massive blind spot. So the AJCC Ophthalmic Oncology Task Force is now working to integrate those specific cancer data points. We need to know, did the tumor regress? Did it recur? Did the patient survive?
Making big data actually useful for these rare conditions.
Yes.
And what about artificial intelligence? Is AI coming for the ocular oncologist's job?
Not quite, but it is becoming a powerful assistant, particularly in pathology. Deep learning models are being trained on histopathology slides of uveal melanoma.
What are they seeing that we aren't?
So humans look for specific features. Cell shape, nucleus size. But AI can analyze the texture and patterns of the stroma, the connective tissue, and other subtle features the human eye might miss. Some models are showing they can predict patient outcomes potentially better than standard observation alone.
That's incredible. It's not replacing the doctor. It's giving the doctor a superpowered microscope.
That's a great way to put it.
Okay, let's talk systemic associations. We mentioned the eye is a window to the body. If our listeners are on rotations, what systemic syndromes should they be hunting for?
There are 3 big ones you absolutely must know. First, Li-Fraumeni syndrome. That's a germline mutation in the TP53 gene. It predisposes people to all kinds of cancers, including retinoblastoma.
So a kid with ARB and a strong family history of other cancers.
Think Li-Fraumeni. Second, Cowden syndrome. That's a PTN mutation associated with breast, thyroid, and uterine cancers. And third, neurofibromatosis type 1, or NF1. You'll see Lisch nodules on the iris or optic pathway gliomas.
Those are key for the boards. Li-Fraumeni, Cowden, neurofibromatosis.
Gotta know them.
I want to touch on research methods briefly. How do we test new drugs for these rare cancers?
Animal models are the bridge. The text discusses knockout mouse models, but even more interesting are xenograft models. This is where they take actual human tumor tissue from a patient and transplant it into an animal, usually a mouse with a suppressed immune system.
So you're testing the drug on the actual human tumor, just growing inside a mouse.
Yes. It lets us see how that specific patient's tumor responds to a new chemo agent without risking the patient. It's how we find the next generation of drugs.
We're coming to the final stretch here. We've talked about science, data, and biology, but the book ends on a very human note, mentorship.
Yes. There is a profile of Dr. Friedrich A. Jakobiec, known as FAJ. He was a titan in ophthalmic pathology.
They called him the king of cysts, didn't they?
They did. And there's a story that just perfectly captures his philosophy. A resident once dismissed a lesion, saying, "It doesn't matter, it's just a benign cyst."
Oh, I can imagine that didn't go over well.
Not at all. Dr. Jakobiec argued that everything matters. To be a true expert, you have to understand the embryology and origin of the benign things just as well as the malignant ones.
Because if you don't understand the harmless cyst,
You can't truly understand the dangerous tumor because you don't understand the tissue it grew from. It's about rigor.
it is.
And his advice for young doctors was simple. Write case reports. Don't feel like you have to discover a cure for cancer to publish. Documenting the unusual cases, the outliers, is how we build that experience base we talked about at the beginning.
That is such solid advice. So to bring this all together, we've gone from the genetics of a child's eye tumor to the salmon patches of lymphoma to the algorithms of AI.
It really highlights that ocular oncology is the ultimate team sport. It's not just the surgeon, it's the pathologist, the radiologist, the data scientist, and the patient. And critically, it's about global equity.
Before we sign off, we did promise a review exercise. We want to make sure that MOLS acronym stuck.
Right. This is for you, the listener. Imagine you are examining a patient's eye. You see a choroidal lesion. Using the MOLS acronym, what are the 5 risk factors you were checking for?
I'll give everyone a second to think. MOLES.
Got them. M, mushroom shape. Remember, that's the britchous membrane rupture.
O, orange pigment. The lipofuscin, the metabolic stress.
L, large size. E, enlargement over time. And S, subretinal fluid leakage.
If you got that, you're one step closer to thinking like an ocular oncologist.
And I want to leave the listeners with one final thought from the book. The editors dedicated this work to their children. And it's just a reminder that behind every statistic, every slide, every data point, there is a human life and a family hoping for a cure.
Beautifully said. That's a wrap on this deep dive into global perspectives in ocular oncology. Thanks for learning with us.
Thank you.